Very good morning. I welcome you to this instruction course. This is one of the instruction courses that we have been regularly doing over last couple of AIOS. Instruction course which is from multi-speciality or super specialty doctors who would like to give a few tips to their anterior segment friends and colleagues on how to manage their complex cases a little better. I would like to acknowledge and thank Dr. Avninder Gupta sir for designing this course, being the mentor for all of us on this course, and quite a few innovations are from his mind, I would say, and slowly then have been taken over by us on at Center for Sight. And I would now request Dr. Avninder Gupta to initiate the course, and then I'll go on with the first presentation.
Uh, uh, he'll be speaking about vitreous decompression in cataract surgery with shallow AC. Actually, this is an instruction course where anterior segment surgeons have come to us with various problems, and we have tried to help anterior segment surgeon to make their surgery easy. This technique of vitreous decompression actually was discovered with Dr. Hirsch and Dr. Ritika, because Dr. Hirsch comes with always comes ki the pressure is not coming down. I have given mannitol to the patient, and still patient 40. I'll open the eye, and most probably it will lead to sudden hypotony leading to expulsive hemorrhage. So we said ki yes, we'll do slow decompression of the posterior segment and reduce the intraocular pressure. That way your chamber will also decrease, and your surgery will also become easier. We had an phacomorphic glaucoma, and that Ritesh will highlight in his talk. And we helped our anterior segment to do the nice job with minimal complication. And I think Hemlata and all anterior segment, one of the most prolific surgeons of our center, is using this technique. The main thing is ki if we are able to influence our best of the surgeons that this technique will help them, that means we are successful in that. And we have two of the best surgeons from two different specialities, Dr. Hirsch and Dr. Hemlata, adapting to this technique. That means this technique is helpful. Dr. Ritesh will speak on vitreous decompression. Important thing, one thing what I like, all the techniques involves trocar and cannula systems. So a brief introduction about trocar and cannula systems will be given by Dr. Ritesh.
Thank you, Dr. Gupta. So I'll introduce the hero of this instruction course. Can I have my slides? Yeah. So the hero of this instruction course is our Procar cannula system, which comes to the rescue, especially in the initial few techniques that we are going to be showing. 23 gauge micro incision trocar cannula system forms the backbone of this instruction course. It is imperative to understand its component and usage to fully utilize the tricks shown in the subsequent videos. A typical non-valve trocar cannula set consists of three 23 gauge trocar cannulas, an infusion pipe, and three scleral plugs. Trocar cannula consists of a sharp spear-shaped trocar threaded over which is a round-bodied cannula. In a phakic eye, the cannulas are inserted 4 mm from the limbus. The conjunctiva is retracted slightly, and the trocar cannula is inserted in a two-step fashion, initially going parallel to the limbus for half its length and then going perpendicular to enter the sclera. The infusion is secured in the infratemporal cannula. And the superior ports used for the vitrectomy cutter are plugged till further use. it is a relatively simple technique which can be mastered easily with little practice. Now coming on to the first talk of this IC, that is vitreous decompression, as Dr. Gupta rightly pointed out, it's a technique which has picked up over a period of time. Now we have regularly in our OT list surgeons asking for pre-planned vitreous decompression for their tough surgeries. So what is vitreous decompression? We know phacoemulsification for anterior segment surgeon in shallow, crowded anterior chambers is a challenging situation. This is commonly encountered by them in intumescent cataracts, in cases of phacomorphic glaucoma, hypermetropes, small eyes, or in cataracts in eyes with pre-existing glaucoma. And the problem in these cases is that when they undergo phacoemulsification, it leads to a lot more endothelial compromise. The chamber is very shallow. It's difficult to perform the surgery. There is a risk of descendant detachment. The capsulorhexis very often can extend if there is a lot of upthrust coming from behind, and zonular dialysis, vitreous loss, causing because of PC rent, iris prolapse, and all. And the more worst of situations, you can land up with even expulsive choroidal hemorrhage. So keeping all this in mind, it is a standard practice to kind of decompress these eyes. So earlier what was being used, what is generally done is a controlled paracentesis is done, a lot of viscoelastic is injected. IV mannitol is used to contract the vitreous so that the upthrust can go down, but these generally, what we have seen may not work in all cases. So then what all could have been done? So what has been advised in literature is you can do a direct vitreous tap with a needle. You can do a vitreous tap with a needle aspiration. Some people also recommend going directly into the lens, aspirating the lens matter, especially if the lens is intumescent, a lot of liquefied lens matter is there. Or you can even do a partial pars plana core vitrectomy. But all these procedures done blind are fraught with a lot of risk. There is a risk of complication, detachment, vitreous pull, vitreous. Uh, so all these can lead to a lot of tricky situations. So we came up with this technique. This was a video of an 86-year-old female who had presented to us with an advanced cataract. 10 days ago, she had been advised somewhere else to go for surgery. It was a phacomorphic glaucoma. Preoperatively, she was prepared with mannitol, topical anti-glaucomas, but the pressures were very high on the day of surgery. So what we did was we put a trocar cannula 3.5 mm behind the limbus, and we just left it open. Most of these patients are elderly patients. The vitreous is liquefied, and it tends to prolapse out of these non-valved cannula. And then now using a cutter at high cut rate, low suction, without causing any pull on the vitreous which is prolapsing out is gently just cut at the level of the opening of the cutter. It causes the pressure to go down significantly. The anterior segment surgeon very easily is able to now maneuver their instruments in the eye, able to carry on a good rhexis, which otherwise in a high pressure situation with a lot of upthrust is not very easy to do. And a comfortable phacoemulsification can be done in situations like this. So as you can see here now, our anterior segment colleague has started doing phacoemulsification. The beauty of this procedure is that if at any stage during the middle of the surgery you again find the thrust going up, like now in this particular situation, there was again an upthrust and there was a small iris prolapse happening. That means the pressure was high again. You can open the trocar again. You can keep it blocked with a plug. You can open the trocar again, allow a little more vitreous to decompress out, do more vitrectomy at the opening, get the pressures down so that the surgeon can complete his phacoemulsification much more safely and comfortably. And that's the surgery being completed and the IOL being inserted and the wound secured, and in the end the trocar is just removed with a slight pressure onto the port. So in a tricky situation, also with the help of a trocar cannula system and vitreous decompression, one is able to carry on these surgeries in a much more safer manner, in a much more controlled manner without any risk of complications. Thank you.
Very nicely elucidated. experiences of Dr. Ritesh. One thing is very important here, that you don't use valve cannulas, because if you use valve cannulas, then you will have to go inside, and there won't be any prolapse of vitreous or liquefied vitreous from the posterior chamber outside. So non-valve cannula is a must. Any questions from the audience?
So, so I would prefer a 23 gauge. It gives an advantage of it being a cannula, so a sutureless entry exit, but at the same time have a good enough a bore to allow for enough liquefied vitreous to prolapse out. A 25-27 valved may not be the ideal choice for these situations. And see, these 23 gauge Croccar cannulas are available easily. They are quite cheap, easily available, and can be purchased standalone. You need not purchase the whole packs for this.
Uh, vitreous will not come in 27 and 25.
Yeah,
20,
25-27
yeah.
is not okay.
Gel vitreous won't come
It's
out.
too small an opening.
And second thing, with decrease in intraocular pressure, there is an advantage that rhexis will not extend. So you will be able to perform rhexis, although lot many surgeons will say, "Ki I'll do a femtorhexis," but if femto laser is not available, if you have a very shallow anti-A chamber, in cases of hypermetrope, mature cataracts, uh, hypermature cataract, phacomorphic glaucoma, this technique works wonderfully. And next, I'd like to invite our president, uh, who has graced the occasion by coming here and delivering a talk, Dr. Lalit Verma, who doesn't need any introduction. We'll be talking in one of the most common situations faced by anterior segment surgeon, that is posterior capsular rent. Now, many of you debate whether posterior capsular rent should be managed from the anterior segment or from the posterior segment. So he'll highlight which are the best techniques of managing posterior segment surgeons, uh, telling us the advantages and disadvantages uh, of the technique from anterior segment and posterior segment. Dr. Lalit Parma.
नहीं नहीं कुछ ऑफ नहीं है अभी हो रही सकता हूँ.
Actually, this concept was first propagated by Dr. Abhay Vasavada, but how we landed up into a situation with this technique is we had an injury, needle stick injury, which caused an traumatic cataract, and there was a vertical slit in the anterior capsule. Uh, our anterior segment surgeon, Bharat, was operating that day. Our anterior segment surgeon said that I'll remove this. The moment he entered into the anterior segment, he realized that there is a vitreous mixed with cortex. So he was not able to perform his routine surgery. Then we went from behind, and you will see in the coming videos how this surgery was managed. And the result was excellent, and patient recovered with well-centered lens, no cataract, and with 6/6 vision.
Thank you, Avnindra, and thank you, Ritesh, for this very apt course, Holding Hands. You see, I had coined this term APPA. Sometimes anterior segment surgeon holds hands, sometimes posterior segment surgeon holds hands of the other party. But by and large, the posterior segment surgeons are called for whensoever there is PCR or the vision is not getting fulfilled. And all the topics here are when posterior segment surgeon comes to the rescue of anterior segment. No financial disclosures here, and this slide is mandatory for all of us to put as second slide. So PCR does happen with everybody. Even the greatest of the surgeons will have sometimes PCR. And what I believe is it's the overconfidence generally which leads to PCR, or when the surgeon is in a hurry, and or at the fag end of the case, or he is nervous because of VIP patient. Then these are the situations where I have seen the anterior segment surgeons sometimes sweating also. So issue is not PCR, even if it happens, but issue is how in that situation of panic, what is the approach of the anterior segment surgeon, or how it should be managed. So I'll show one or two videos here. So this situation is there where PCR has happened and you see what the surgeon is doing. This section has been enlarged and you do a vitrectomy with in the left side some infusion, and in the main hand, right hand, you would keep doing vitrectomy. I'm not sure whether the vitreous is getting cut or not, but the movement of the cutter is definitely there. Whether vitreous is getting engaged here or not, it's not very sure. Because this is a blind kind of vitrectomy, you are not seeing what you are cutting. Sometimes if it is formed, you may, but generally it's a blind vitrectomy. So you see another situation here. Here again, PCR has happened. You could have done this same vitrectomy, but surgeon is wise enough, he injects Tricot. Advantage of Tricot is that it gets adsorbed onto the vitreous fibrils and makes the invisible thing visible. So you are precise in your approach, that you will approach this white colored, this vitreous. You see this fibril here, which could not have been picked up in case you are doing a blind, unstained kind of vitrectomy. So this is more definitive, and this is what I would advocate, or all our group here does this. So you inject some crystal Tricot, wait for some time, and do this Tricot assisted vitrectomy if you are anterior segment surgeon and not used to going from pars plana, or hesitate to go from pars plana. So what are the do's if VR support is not at hand? Because I see most of the anterior segment surgeons are hesitating to enter from the pars plana area. So do a good vitrectomy, but it should be a Tricot assisted kind of vitrectomy. And aim should be that nice round pupil should be formed at that time. And how to do it? Do not pull the vitreous too much. Suction should not be very high. And it should be a good cutter. Good cutter means it's not a cutter you have not used for ages and ages. Suddenly you start, in a panic situation, any cutter. So it should be a good, maybe fresh cutter. And handled, the infusions should be slow. And since you are going from the anterior segment, it is possible that you may damage whatever capsule or rexes you have. So you should try to leave behind, because patient rehabilitation also is very, very important. And leave behind as much capsule or rexes, because we can support the sulcus fixated lens here. And do not dive into the vitreous. Your plane of operation should be in and around the iris only. And movement should not be like, cutter is like this. Cutter should be like this, horizontally placed. So you can do it. The other question very frequently asked is, after doing this, you can easily insert this lens. This situation I'm talking when the VR support is not at hand and you are alone doing it, and then put suture there. Suture is important at that time. So these couple of things, if anterior segment surgeon follows, I think the posterior segment complications can be avoided, CME or even detachments or traction onto the vitreous. So this should be followed by all anterior segment surgeons if they have PCR and if the retina support is not at hand. And this, I think, Tricot does help in doing a specific job, doing a job under visualization. So this should be learned. So in the event of crisis, so these photographs which I have taken are actually patients who had eventful surgery in the form of PCR. Some will have detachment, some will have colony edema, some will have CMEs. So other thing which we say, do not do this fishing kind of job if the nucleus is there. So respect the vitreous. If you want your patients to respect you, you have to respect the vitreous. The problem is it's not visible, so therefore you put Tricot. So as I said, why chromo or colored kind of vitrectomy? Because clear vitreous is difficult to see, and triamcinolone gets absorbed and makes the invisible thing to easily visualization, and thus facilitates precise job, complete job, and time taken is also less. and very important is reduces the chances of these complications. The other thing is pars plana approach. Because the reason of pars plana approach is that if you are doing this kind of vitrectomy, even if you are doing trichord assisted vitrectomy, if the PCR is liable to get enlarged, as was shown in this YouTube video, suppose, let me come to the video state. Suppose this is the, posterior capsule and this is the rent. Red is the vitreous. And if it is, done from behind, so this vitreous is collapsing down. This is, somebody is pulling the vitreous down from the pars plana. And whereas if you do from anterior segment, that is pull the anterior segment vitreous, this is liable to get enlarged. So that is the reason I think why we do not advocate. Let me exemplify with this case with AG was referring. This was a patient who had this traumatic cataract, and we knew it is possible that patient may have, PCR or pre-existing rent there. So this was the beginning surgery, rhexis done, aspiration being tried, but since the vitreous and lens matter was admixed, it was not coming out. So that is when the posterior segment surgeon intervenes, makes all these ports, goes from pars plana 3.5 millimeter behind, makes all these 3 ports, and be very, very careful that you do not damage the capsular support, because that will support the lens, and take out this cortical matter. Use a mixture of both cutting suction and only suction sometimes, and remove this matter, which should not take much time. Cutting is also important, because otherwise you will put a drag onto the vitreous if only suction is used very commonly.
Alex, since most of the anterior segment surgeons will not have access to the posterior thing, is it possible that we go deep into the from the rent and then start?
That is known as far weight kind of technique. Far weight is technique described by Amar Agarwal, where he goes from the anterior segment limbus approach, goes deep, which is not advocated because you will have a lot of corneal complications, and precise job cannot be done. You see, we do not advocate that you dive deep into it. He sometimes will go deep into it and take out the nucleus matter also. Yes, Dr. Gerard.
I have one question and one comment.
Yeah.
One question, if you're doing it from anteriorly and you put the trichord in, if you leave any in, will it still absorb?
Yeah.
later on?
There's no issue. Trichord can be easily left behind few crystals. In
will absorb.
fact, sometimes deliberately we do it. We leave behind because a steroid inside the eye, unless you are unlucky for endophthalmitis, but by and large, this will aid in controlling inflammation and reduce the chances of CME also.
And I see you didn't.
So in all retinal surgeries also, once we stain the posterior hyaloid, we deliberately leave behind some crystals of trichord.
And I see that you didn't use trichord when you did from the pars plana.
Not required.
Okay, next. For the anterior segment surgeons, I see you put trocars in, and a lot of anterior segment surgeons are not adept at putting in a trocar. My comment is this: you could just make a penetration with a small blade and put your phaco tip in there, and perhaps have the inflow from your original limbal incision, inflow through, keep the bottle low, inflow through the incision, and just put your phaco probe in without the trocar.
All these combinations are possible. But last message I will just share with you. Then I think we'll discuss on this comment. Yeah. Vitrector only, because phaco probe the dimensions and all, because we want thinner spots.
It will not cut the vitreous.
Yeah. So I'll just finish. Let me finish. This is a small video only. So you see how the surgeon is, taking care of this cortical matter in leaving behind enough capsular support. So now that this job is done, so this is the message we wanted to convey, that PCR management from the limbus route, the possibility of rent extension, possibility of traction onto the retina and the macula, and possibility of leaving behind residual vitreous. And same thing if you manage from the pars plana, possibility that PCR extension will be less, traction will be less, and possibility of removal is more. So do this in case you are afraid of entering from pars plana. And do not do this. First, you do not do this, do this. But best is to learn to, you have to come out of that fear that, all of us are surgeons. And insertion of trocar canal not a big job actually. So learn to use this trocar canal system because that is more safe and avoid all these complications. You see, anterior segment surgeon may get out of that tricky situation immediately, but some of these complications occur late. So that is the issue. So other thing what Dinesh was reacting to was that you can't put a phaco probe from there, even though you see all these phaco machines have a component of anterior vitrectomy, but you can't because that will not cut the vitreous properly.
Not the phaco, but we put the vitrector.
Vitrector,
But
then
I'm
it's
saying if you have cortical material or even nucleus that's up front, have your rate slow, like 500.
Yeah.
You're going for vitreous, then you're going to 1,000, 2,000.
So what we can do is for infusion, we can put an AC maintainer. If you don't want to go from the posterior segment, you can just put an AC maintainer. So the cutter works as an aspiration and the fluid comes from the AC.
So that, I thought you were referring to the same technique. You can, infusion you can have from the anterior.
The advantage of using a trocar cannula over just a direct entry is like the trocar cannula, when you're going in and out through the trocar, your traction on the vitreous space or the
much
vitreous is
less.
not being pulled into the port there. If you do a direct entry with an MVR blade, each time you go in and out, there are always chances that you may be pulling the peripheral vitreous out through that. So putting a trocar, it's a very simple technique. That's what we designed through this instruction course. We want anterior segment surgeons to just forget this fear of putting the trocar. It's a very small step. I mean, you're great surgeons.
It's a small step, but if the trocar is old, you can get into big
Yeah,
trouble.
yeah. So good trocar.
It's an open eye, so either you first suture the wound and then put the trocar, and you have to have a very sharp, fresh
Yeah.
trocar.
So
You can't use an old trocar for this kind of case.
What can be the complications?
The whole thing will come out.
Because you see, if you have an old trocar, it will not go smoothly inside.
Even if it is fresh and
Fresh, it will go like a butter in,
technique or
huh?
not
It
used
will
to
go
it.
like a,
Like a makhan,
through
like a-
through no, hot knife
Yeah.
through butter.
They can always suture the tunnel and.
So you have to touch,
see,
suture the tunnel.
if you're
before-
using a old or not a good trocar, and when you're putting it, you're putting too much pressure on the globe, and the wound is open, everything will
You
prolapse
see, the
out.
problem is if you are exerting too much traction, the whole globe will deform and whatever is open, contents may come out. Whether it is IUL, vitreous, whatever, it is liable to come out.
So
in an open wound.
two things what you should do is you should be away from the tunnel and away from the paracentesis. Because if you are just below the paracentesis or below the tunnel, with new trocar also you will open it and you will cause a decompression or a collapse of the globe. Once the globe collapses, you won't be able to put, you need a hard globe for insertion of trocar and cannula.
The other way of doing that is you can take a 23 gauge LVR, first make the port through that, and then pass the trocar into that.
That is what this gentleman was saying.
So you put the 23 gauge LVR, and then put the trocar.
Another suggestion,
Yeah.
put viscoelastic in the
So
anterior
then it
chamber.
will, then it's
Suture
already
it. We now have a firm eye, and maybe that would assist.
Yeah, that's what
the,
we
trocar.
usually do it. That's what we usually do it before inserting a trocar cannula.
The other thing is that if you're
Yeah,
using
yeah.
sorry.
There is a PCR in the presence of the nucleus or
Yeah.
a few pieces of
Nucleus
and
down-
we are
down.
tempted to take them out first. That will also put traction on the vitreous.
That is the last step. You see, first is to remove the vitreous. Don't rush out.
Three pieces fall back.
Yeah, let them fall back. Let them fall back
And that
because,
is what the vitreoretinal surgeon
yeah,
does.
because unless you are well versed with the vitrectomy techniques, do not chase that, fragment of nucleus. Let it fall back. Because aim is to cut the vitreous and free the nucleus from all those things. Because if you try to chase back, which is the temptation that whatever is there, take it out. That is what causes the problem.
Hemlata.
Because once you take it out, without doing an adequate vitrectomy, then the purpose does not get solved and traction or pull on the vitreous is always there.
Concentrate on clearing the AC and the
Of the vitreous. The vitreous should be, cut. And if it falls back, the job becomes actually easier for the VR surgeon.
and then in that situation do we put a lens or that?
Yeah, go ahead and put the lens.
How hard the nucleus is.
Yeah, even the, except very hard Niagara or very dense brown, otherwise most of the phaco-fragments can take care of majority of the hard nucleuses through the pars plana. We have a lot of videos to show that, maybe somebody will show that. Even the hardest, it may take some time, but it will come out. Very, very hard, which nowadays we hardly see actually. So that is the only thing. Or sometimes if it's a nanite patient, we may not advise, but by and large we advise that go ahead and put the lens.
We often have very hard cases.
Yeah.
We do have.
So if not, allow the retina surgeon, he will also put the lens in the sulcus.
And sir, the second question is, my machine has a 20 gauge retractor. Can I do a pars plana retractor with that?
If you have,
You
why not?
can
You see,
with-
all of
But
us,
it doesn't make a difference. You can ask them to give you a 23 gauge retractor. The retractors are not different, and only the tips are different. The machine is the same. There is no difference. So you can ask them to give you a 23 gauge.
But in any case, 20 gauge will not go through the trocar.
No, you will have to make an
you
MVR
will have
port.
to make MVR opening. MVR opening.
One point more, if you haven't, like the case which was shown here, the IOL had been inserted when the tripod assisted. with
Second
the
patient,
tripod.
yes.
But if that has not been done, if the IOL is not there, then be careful not to put too much of tricot. You should put a very little amount of tricot because otherwise it will go down. And then if it's a very large amount inside,
Yeah,
it can
tricot,
cause a secondary glaucoma.
very small amount should be put, I agree. Because
How much?
A drop.
Less than 0.1.
Sir, ideally,
0.02 or so.
Point 1 or
0.02.
0.02 ml of tricot is
Tricot,
put in
pure.
the anterior segment.
Yeah.
and normally whatsoever we have done, we do not use that preservative-free tricot. We use the normal standard tricot. Some companies are selling the preservative-free Orocot,
In
can I
this
say.
situation, you
that-
need the
Yeah.
normal tricot.
Yeah.
So
Not
because in couple of webinars it is emphasized that use preservative-free. That does not work so well. That does not stain the vitreous at all.
It is very liquefied. It tends to float more into the vitreous cavity rather than getting stuck into the.
You won't see it.
Yeah.
More
Yeah.
difficult to see also.
no, the problem is if it goes into the mid-vitreous cavity, then you will find difficulty in removing it. That is the problem. If you have a large rent and you have done a vitrectomy, so the ideal situation is कि you do a vitrectomy, put a lens, and then put a tricot to see any vitreous fibrils are coming into the anterior segment or not. But if you have a rent and if you do an tricot assisted vitrectomy, it will go into the mid vitreous cavity, and suddenly your glow will become white, and you won't be able to see anything in the anterior
So
segment.
retroillumination glow, everything will be white only.
You don't dilute the.
No, you don't.
Direct.
So very little. I'm not talking of putting 0.1, we're talking of 0.02. That means 1/5 of that, just a little bit, just in the AC. You don't need too much. You just need a few crystals to visualize it.
Final word on the timing of putting in the right at the
The
beginning.
ideal is what we just said. You put in the IOL, you can now clear the. But if you think that you need assistance to
लगा
figure
लेते
out where it is, you can put, but then be careful not to put too much. If you put too much, it'll go down.
So another thing, any case that an anterior segment surgeon can consider for phacoemulsification is good enough for a VR surgeon to take out from the posterior root. So you can put IOL in those cases absolutely without any fear of.
Talking about the timing of putting in that.
So ideally, as Dr. Gupta said, do first a vitrectomy, put an IOL, stain, check whether the vitreous is completely removed or not. Now I would like to invite Dr. Hemlata Gupta for our next talk. She'll be talking about chandelier assisted cataract surgery. This is a technique which has its origin from the fact that very often cataract surgeons need to handle cases which don't have a great view because of a hazy cornea or a hazy media, and how this technique can help in those situations. Another often instruments from the VR machine which can be useful in these cases. Over to Dr. Hemlata.
A very good morning to all of you. Thank you, Dr. Ritesh, for having me here. I'll be talking about the chandelier illumination assisted phacoemulsification in hazy cornea. So all of us encounter such dense corneal opacities in our day-to-day practice. Doing cataract surgery under conventional microscopic illumination is a real challenge in these eyes because of the poor intraoperative visibility. And why does that happen? Because light from the microscope in these eyes is unable to enter inside the eye or is scattered, causing poor red glow, and hence we have decreased depth perception. So there are various techniques to enhance the intraoperative visibility. One is we can use the intraoperative trypan blue dye, and creation of the pupillary sphincterotomy is also one of the techniques, and use of endoilluminators that can be placed either via the anterior chamber or via the pars plana route. Now, the interior chamber illuminators work really well when you have mild to moderate corneal haze. The only problem is that you need a very good trained assistant to hold the light pipe in position, because if the surgeon wants to do bimanual manipulations, then it could be a problem. So that problem is not there with the chandelier illuminator. So how does the chandelier system work? So when you have a corneal opacity, as we know that the light from the microscope falls on the cornea, and because of the opacity it gets scattered back, and that is what is leading to poor red glow. But with the wide angle illumination of the chandelier illuminator, when the light falls on the cornea, it gets reflected back, and this just bypasses the corneal opacity, giving you a very good red glow. So you get a good intraoperative visibility with increased depth perception. And why the conventional light sources do not work with this? Because with 20 gauge, when we used to do 20 gauge vitrectomy, and the illuminators used to use sources like halogen and metal halide. But when we shifted to smaller gauge vitrectomies, the illumination that we receive we achieve with the halogen and metal halide is 50% less. To compensate for this decrease in brightness, the newer light sources were introduced like xenon and mercury, and the kind of illumination we achieve with the xenon and mercury sources is equivalent or better than the conventional light sources. So there are various standalone xenon light illuminators that are commercially available, like Photon, Accurus, Brightstar, Constellation Vision Systems, Stellaris, Spacey. And these mercury vapor illuminators is much better and brighter source of illuminator with luminous efficacy reaching up to 402 lumens per watt, and which is brighter than any commercially available xenon light illuminator. So what are the indications? We use it mainly for the one-eyed patients who may be at high risk candidate for combined corneal transplantation and cataract procedures, where we feel that the patients might achieve adequate vision after cataract surgery alone. However, most of the surgeons are reluctant to touch such cases, fearing the intraoperative complications because of poor visibility. I'll show few such cases. So this is the first one, where the patient had this dense leukomatous corneal opacity in the center. So we are placing the chandelier in the pars plana area, and when you make the light pipe vertical, you can see that you get a very good red glow bypassing the corneal opacity. So then we switch on the microscopy light, make the ports, stain the capsule with the trypan blue dye, and once that is done, we shift to the chandelier illumination and perform the capsulorhexis under chandelier illuminator. You can see how good the red glow is because we have stained the capsule, so margins of the capsules are visible throughout the surgery. So the problem with the corneal opacity is when you do the intraoperative manipulation, you chop the nucleus, so you don't have any idea of the depth perception. But with the chandelier illuminator, you can see that you know where you're working. So all the pieces are emulsified safely. See how poor the intraoperative visibility is if we don't use the chandelier illuminator. And then this cortical matter is being aspirated. Capsular margins are clearly visible. And then we inject the intraocular lens safely inside the bag, which is not possible in many of these cases under conventional light because we don't know whether the IOL has entered inside the bag or the haptics are there inside the sulcus. So in the end, we just pull it out. No need of suture. It's a self-sealing wound. So we just need to press it for some time. So it self-seals. So this is another case with even denser opacity involving most of the cornea with a very, very poor intraoperative visibility. So again, we are using the chandelier to assist in the phacoemulsification. So once the light pipe is in position, then we stain the capsule, see how dense the opacity is. And now when we perform the capsulorhexis with retroillumination, you can see that yes, now once the first nick is given, you are able to see the rhexis margin. The problem with the dense corneal opacities is if you're not able to visualize the rhexis margin, there are chances of capsular tears intraoperatively, and sometimes while doing the the cortical aspiration, you tend to pull out the rhexis margin, and that can lead to zonular dialysis. So all these complications can be prevented if you use chandelier. So it, makes the surgery really safe as compared to the normal conventional microscopic illumination. So even polishing is possible. We get such a good view that even polishing is possible in the end. So here we end the case. So I'll just show one more case because that patient had really, really bad cornea, and we were, reluctant to touch this case because this patient was one-eyed and was having glaucoma also associated with it, because these patients have number of ocular comorbidities associated like compromised endothelium and glaucoma. But then retina people are very confident, so they advise us to use chandelier. So this patient again had very good visual outcome. So the beauty of the chandelier is that it just bypasses the corneal opacity. Now you're not able to see any corneal opacity and you get a very good red glow. So even in such bad cornea, we were able to perform phacoemulsification like we do in a routine surgery. Another problem is when you're doing the phaco procedures, many times there is shattering of the lens fragments, and small pieces, they go behind the iris, or they they get lodged in the subincisional space. So because of the poor visibilities, you miss those out, and already this is a glaucomatous eye and this compromised endothelium. So those lodged pieces lead to intense inflammation in the post-operative area. So it's very, very, essential. It's essential to remove all those pieces carefully before you end the surgery. So with this kind of visibility, it's possible to remove all the pieces in the end. You can see that there are subincisional small nuclear fragments. So every single small fragment is visible. So once you, complete the nucleus removal, then we safely take out the cortical matter and implant the lens in the end. So the advantages of the chandelier illumination is it's a smaller gauge surgery, and there's easy entry without the need of any conjunctival peritomy. By virtue of its design, it's self-retaining, so allows bimanual procedures. It has wide angle illumination. There is 4-fold increase in contrast and 2-fold increase in resolution when you place the illuminator behind the cataract. There is very less corneal scatter and better anterior segment visualization. You avoid the need of high-risk open sky cataract surgery, and it's very easy to remove, leaving the self-sealing wound. Phototoxicity is still a concern, and but with the newer commercially available xenon illuminators, they have modified it and lowered the wavelength, cutting off the ultraviolet and blue lights to reduce the phototoxicity. But it's more of a concern in the retinal surgery. Since the cataract surgery duration is short, we are not bothered about the phototoxicity with the cataract surgery. So to conclude, chandelier illumination is a very helpful technique for enhancing the intraoperative view of the lens for safer phacoemulsification through a very hazy cornea. It provides a high-intensity, hands-free source of illumination and can be safely adopted by most of the cataract surgeons in the presence of mild, moderate to even denser corneal opacities. Thank you for your patient listening.
Thank you, Dr. Hemlata, for showing us such difficult cases. Two important tricks into the surgery is, whenever you put a chandelier illumination, ask your assistant to make it vertical. Because if it is horizontal, it will give a whitish kind of a hue on the lens, and you will find there will be not much of a glow. So ask your assistant to make it vertical. The moment you make it vertical, the glow becomes absolutely red. But if it is horizontal like this, it shines into the cataract and you won't get a good glow. Uh, Second thing is, whenever you are introducing any instrument into the eye, put on the microscope, and once you are performing the surgery, put off the microscope. All the surgery is done under darkness. It's not under microscope light. The only visualization what we see here with the chandelier illumination, and that is the trick. If the microscope light is off, then you get a good depth of perception. The moment the microscope light is on, you won't get a good depth perception.
Hemlata, Dr. Dinesh was asking how much did the patient see? Because the
How much
opacity
is
is
the
very
visual
much.
rehabilitation in the
So the
presence
thing
of
is
such
that
patients?
these patients are like,
I also wanted to add that in such a situation, would it not be prudent to do a peripheral and complete
Of
iridectomy?
PI, or sorry, or
Complete
sphincterotomy.
the sector
Either
iridectomy.
sphincterotomy
Yeah.
or a
Because
complete
if you
iridectomy.
can't see
Optical
anything,
iridectomy.
if we do an optical iridectomy over there, it will be very
So
beneficial.
if you have seen these cases, most of the patients they have central opacity. The inferior area and the nasal and the temporal is still. So the patient is able to see.
CI is
See.
important.
CI will be.
Actually, cataract surgeons are very reluctant to do either a sphincterotomy
Yes.
or a CI. I mean, even when I write down, please do it, they
We
tend
don't
to avoid it. So
The
I don't
patient
know
was
why,
very
but
happy
your
with a
patient
good
is not
vision,
in the
but
CI.
then yes, that is a very good idea. So
The last
next
patient what
is
he showed improved to 618 vision.
yes,
That's okay,
the
but
patient was very happy.
We totally agree to you.
Please understand what we are
Yeah,
doing.
Yes, the iridectomy we should be doing.
Many a times we are working for ourselves and not for the patient.
The sector iridectomy is a good idea.
Yes.
We'll do that next
Next
time.
time we'll see this. So we Radhika, do you agree?
Moving on to our next
सिखाते थे बाद में भूल गए.
Moving on to our next talk, I would now like to invite Dr. Amninder Gupta. Sir, he'll be talking about using micro scissors and forceps, another tool which we VR surgeons routinely use for our VR surgeries. How we can use those tools to help reconstruct anterior segment. Over to Dr. Gupta.
First of all, I'd like to thank Dr. Ritesh for giving me this opportunity. I'll be talking about micro scissors and forceps in anterior segment reconstruction. In the area of super specialty, many a times we are unaware what is happening in other specialties. And we also forget to peep into other specialty about the new instrumentation, what we get. The machines, how can they help in your specialty? And somehow I feel retina is one specialty where the machines are more developed, the instrument are more microsurgicals, because we are doing 23 and 25, 27 gauge surgeries. Uh, 23 gauge and 25 gauge micro scissors and forceps were first introduced in vitreoretinal surgeries. These instruments have found way into various anterior segment surgeries, and one of these surgery is pupilloplasty, a surgical procedure to alter the shape or functions of the pupil. And this has also helped us in doing D6 and glued IOL. This is one of the patient of traumatic subluxated cataract with mid-dilated pupil. MICS with endocapsular ring with IOL was done. Patient had 6/6 vision. Halos due to edge effect of the IOL was disturbing. That patient was not able to work. So what we did here is a Siepsel snot. You can see the large dilated pupil, the subluxated lens. Pilocarpine was introduced into the eye, and you can see a constriction of the pupil. A paracentesis was made at 2 o'clock position. A 10-0 needle on Marceline suture on ST-T6 needle was introduced into the eye, and the iris tissue was taken into the needle, and then it was docked into the cannula and brought out of the paracentesis. Once the needle is brought down, you have two sutures here. This suture edge we'll call it as a distal suture, and this we'll call it as an proximal suture. So what we do now, we go within 23 gauge forceps and pull the proximal suture out. And now what we see here is there are three sutures. This is one, this is two, and this is three. So you cut this suture from here, and from this suture you will take a loop. And if you take three loops, then you will have to do a 3-2-1 type of a loop. And if you take four loops, that we call as a four-throw pupilloplasty, you won't have to take 2-1 loop again. So the suture four throws are taken, and these two sutures are pulled, and you can see the knot sliding inside, and this we call as a sliding Siepsel's knot. And the second throw is taken, and at the end of the surgery, the sutures are cut with the help of a 23 gauge curved scissors. And you can see 2 millimeters round pupil. And at the end of the 1 day post-op, you can see a nice 3 millimeters pupil. There was no glows or halos, and patient was now able to drive and do his normal activities. This is one of the patient who had subluxated lens with retinal detachment. So we did a lensectomy, vitrectomy with silicone oil. You can see a large inferior SI. This is an emulsified silicone oil. So what we planned in this patient was aphakic. So we planned to remove the silicone oil from the anti-H segment after putting viscoelastic. Flaps were made at 3 and 9 o'clock position. The IUL was inserted, and the tip of the IUL was caught with the help of a 26 gauge forceps and then externalized temporally. The assistant holds this haptic. The second haptic is internalized and then externalized. Once both the haptics are externalized, it is internalized into the scleral tract, which we create with the help of a 26 gauge needle. After doing glued IUL surgery, what we did is pupilloplasty again. This is fourth throw pupilloplasty. The iris tissue is engaged into ST6 needle and then docked into an cannula. The proximal suture is brought out with the help of a 23 gauge forceps. 4 throws are taken, and the distal and the proximal sutures are pulled, and at the end of the surgery you can see we have created a round pupil, and this, lucky for this patient improved to 6/9 vision. This is 1 week post-operative vision with clear cornea. This is one of the patients whom I operated somewhere around in 2015. This patient had a very good vision of 6/6, but because of the trauma, the pupil was not constricting. So I plan to do an 360 purse string sutures for constricting the pupil. So first I inspect the iris and see how much tissue I can engage. Then a paracentesis then paracentesis made at 3 positions here. One at inferior 5 o'clock, another at 10 o'clock, third one is at 11 o'clock. So we engage the margins of the iris with, and small bites of iris is taken. And you can see we are removing this needle from the paracentesis, and you can see at the end of the surgery there is a small pupil, and we have created an pursing suture at this stage. So this was a post-operative picture of this purse string enhancement of the pupil. So micro scissors and forceps has become an important aid in construction of anterior segment, enhancing our results and making our life easier and happier for the patient. Thank you very much for your kind attention.
Dr. Gupta, for the audience, can you please tell what forceps were you using? What would you ask them to commercially ask for?
Uh, This is a 23 gauge vitreous forceps. These are end gripping forceps. You should have a flat edge of the forceps because then only it will catch hold of the sutures. You can also use glued IOL forceps, which has in serrated margins. And there are two types of forceps in glued IOL forceps which are available. One is curved and one is straight. So you can use either of the two forceps.
So do you prefer a metallic one or a disposable reusable?
You can use either of the two. Both the forceps gives equal hold to the suture.
So
But to cut, you need a 23 gauge curve forceps. Or there are multiple forceps which are available to create an Rexis curved forceps now. So you can use those curved forceps also.
okay. Any questions from the audience? Yeah.
Putting in these forces through the nasal paracentesis is very difficult because the nose.
Yeah,
Are there any tips the curve?
that's why whenever you plan, you should either sit temporally or make a paracentesis on the temporal side. Other thing what you can use is if you are making a nasal paracentesis, because if you use a nasal paracentesis, then making the forceps horizontal is very difficult. So there are curved forceps, glued IOL forceps which are available, which makes the things easier, which you can tilt it to get hold of the suture.
Thank you, Dr. Gupta. That was quite an interesting presentation. Wonderful surgeries there for us to see. Now I would like to invite Dr. Harsh sir to please come and talk to us about posterior AGV, a technique which he now often uses in cases of tricky glaucoma cases.
Thank you, Ritesh, for having me here. And indeed, I'm truly grateful to our retina people and specifically Dr. Avninder Gupta who introduced me to this. Because for putting a valve, unfortunately or fortunately, I keep getting very, very difficult cases, mostly one-eyed cases, operated 2-3 times. So it's quite a mess. And in those situations, sometimes all that is left for you to do is uh, check kar yaar. That there may be some very, very specific areas through which you can put your valve. And putting an anterior valve, yes, we have all seen that in so many situations the valves can be put. But what happens here is we have been putting the valves in all these situations which are very, very common. But anterior valves themselves have their own problems like shallow AC, and you touch the cornea and you are in serious trouble. You can have choroidals, you can have corneal touch, and if you put there's a AC lens plus you put a valve there, it is a recipe for disaster for later things. And I have been telling everybody not to do an anterior valve in eye syndrome because invariably the corneas are not good and you will end up with that. So I tell them that while things are okay, please do a cataract extraction and put a posterior valve, but people will not listen, end up doing a PK later and then doing a posterior valve. Any endothelial decomposition you have, any disorganized anterior segment, any PKs, all these situations are one in which we have to do a posterior valve. There's absolutely no compromise on that. And so this is one of the patients that came to us, completely disorganized anterior segment, one-eyed patient, lens is tilted, pressure is 50, cornea you can see how it is. And that is the beauty of our retina surgeons. So this, Dr. Gupta said, no, doesn't matter, I will do a good vitrectomy. And you actually need not a good vitrectomy, but a very, very good vitrectomy to be able to put this valve over there and feel safe. Because if the vitrectomy is not good, you are in trouble. So this is the standard procedure that we follow: prime the valve and attach it on with non-absorbable sutures. So this is the Ahmed glaucoma valve that we invariably put. And we create a scleral pocket, and after that over to the retina chaps. And always, you know, the big advantage in these cases is that if something goes wrong, you have at least one shoulder to cry on. So it is better to involve as many people in these one-eyed patients as possible. So they do a very good vitrectomy, inject tricord, induce a PVD, which has to be done. If PVD is not induced, if vitrectomy till the base is not clear, you are in serious trouble. And that day we were having another course and the PGI people exactly told me, yes sir, you are absolutely right. We sometimes leave the PVD and within a week you find that things are bad. One of the things that we learned in the paper was that at this edge, we had 2 cases of exposure. So what we learned over the time was, so anyway, this is the same case in which first we had done this posterior valve and then there was a PK done along with a glued IOL. And this was really such a comfortable end result for us. What we learned over the time then was that I would now cover the entire thing with a scleral patch. So we have the initial scleral pocket and then there is a scleral patch behind. Now, and I was telling everybody, do not put this scleral patch here. A lot of people are very comfortable, they'll not make a scleral pocket, they'll just put a scleral patch over there. And what happens is, I had this one young chap who came to me and said, sir, what have you done? My girlfriend just ran away and she said, the moment you look down, you are all white like a ghost. So the trick is that when you have a scleral pocket, this is very, very normal and nothing abnormal looks over there. So you can, but the posterior part is also to be covered with a scleral patch. And people keep asking us, why don't you put Ahmed has also created a pars plana clip which you can put and use this, which we are not using now. We did start off with that, but ultimately what we realized was that the clip is so huge that the moment you try and put it, you just can't get the conjunctiva over it. And the chances of exposures are very, very high. So we gave it up and we are just doing it the way you saw it. So this is just, so basically you have to have a fake or a pseudo fake to do a posterior valve. 23 gauge needle is to be used, go 2 to 3 millimeters behind, keep the tube long so that it is seen in the, initially I thought, oh my God, the tube is coming in the pupillary area and the patient will say, what has happened? None of the patients ever has complained about that. So that is really strange. And so we have done huge number of patients. Now this is 60, which is the paper we published. Malignant glaucoma, superior quadrant was not available. Shallow ACs, many trabs already done. PK with PAS, tilted IOL, bad corneas, which we have seen already, NVGs. So this paper we published in Pan Am Ophthalmol in 2020. And the problems was basically that there could be a vitreous incarceration if we were not careful in the vitrectomy. You have to have good, not good, a really good retina surgeon with you, and you require a regular retina follow. There were choroidals, mild vitreous hemorrhage, vitreous blocking the tube exposure, as I already told you. But the results overall were good, and we checked up the previous papers also. Everybody has said the reduction in IOP was similar in anterior and the posterior group. So no significant difference basically, but please remember, posterior valve is a complex situation. It is a complex procedure. You need a very specialized trained people for that. And so for routine purposes, anterior valve is the way to go. Only when the things that I showed you, the cornea is not good, the AC is very shallow, so you just put it there and then later you get into trouble by having a corneal opacity. It is not going to work out. So please, in these situations, you will have to put a posterior valve. So this is one of the girls which was done outside. Things are very, very bad over here in one of the eyes. So in the other eye, we put a posterior valve. Superior area is already covered with multiple trabs and a valve also. And she did very well. Just a 10-year-old girl, seeing only from this eye now. And that is what gives us hope and a smile. Thank you very much for your kind hearing.
Thank you, sir, for a very nice presentation. You have given an insight, the patients which were refused initially that nothing can be done, nothing can happen, and you are going to go blind. And Dr. Harsh has taken care of these patients. And years together, we have able to benefit various one-eyed patients and bad patients who are maintaining ambulatory kind of a vision and doing their jobs. One thing, many times what happens, you can land up with a choroidal detachment post-operatively, and the skirt of the vitreous enters into the tube. Uh, Once you are doing a resurgery to remove the incarceration of the vitreous from the tube, it is important not to cut the vitreous once vitreous which is incarcerated into the tube. What you have to do, use just a suction and pull this vitreous out of the tube. It comes like a solid thing and or a semi-solid thing, and then you start cutting that. And by this way, you are able to again recanalize the tract, and the tube starts functioning.
Why not use the posterior chamber implant? The things between the iris and the eye. Why not use the posterior chamber implant?
Yeah, so only thing is that when the things are very disorganized, and that is also an option that go behind the iris over the lens.
The chances of bleeding are more.
If you have a comfortable anterior segment, otherwise we can't.
And you are touching the pars placata, so chances of bleeds are high.
No, it,
No, it's
Also it-
scleral fixated is 1.2 millimeter, 1.5 millimeters. So actually you are just bypassing the pars placata. But if you enter through the iris root and pars placata, one or two we initially started this, and we really landed up with a very bad hyphema in these cases. And gradually we learned not to go through the pars placata.
Another course, and this gentleman who's in practice said that I started exactly what you were saying. So it is not, you can't be sure where you are entering. And if you are not sure in private practice, then you can get into a serious mess. So it is better to go into a place where you're 100% sure that things will not mess up.
and the diameter of the tube is pretty more than the haptic size, so the chance of it rubbing the back surface of the iris and all will be much higher. Yes, exactly. So now I would like to invite Dr. Dinesh Talwar to talk to us about anterior segment management in endophthalmitis. When a patient of endophthalmitis lands to any surgeon, the first step in any surgical intervention is to clear the anterior chamber, which may be a very tricky situation. And Dr. Talwar is going to take us through a series of cases to show how best clearing the anterior chamber can be done, which very often can be the eventual step which may be needed. Dr. Talwar.
Thank you, Ritesh. Actually, this talk is more about how retina surgeons should approach the vitreous from the anterior segment. So it's a little more tilted towards the posterior segment surgeon than the anterior segment surgeon. Well, the key to any successful surgical management is good visualization of the field of operation, and as already been discussed just now. And the way to a successful vitrectomy is through clearance of the anterior segment. We know exogenous endophthalmitis starts from the anterior segment, then goes progressively deeper into the vitreous cavity. So if you want to do a successful vitrectomy, you need to make sure that the anterior chamber is clear, and that can be done right from either from the limbal route or from the vas plana route. And then you go ahead and complete the vitrectomy, do an IOL removal if required, and if it's obstructing your view. Now, what are the advantages of the limbal route and the disadvantages? The basic advantages, and that's where the anterior segment surgeon always prefers to go from the anterior route. So also the recent, the new vitreoretinal surgeons, because initial training is always in anterior segment. It has an easy entry, it's more maneuverable. But what is the disadvantage? The main disadvantage is the cornea is already edematous. And so when you enter from the limbus, you have a friable wound which is created over there, which may require suturing, and then the suturing is tough because it cuts through. The leaking of the wound is especially important because it causes hypotony during your surgery, and your surgical manipulations and any scleral depression becomes very difficult to do. So this is just to show you a limbal approach to anterior segment management. As you see, the entry of the infusion cannula is made first. The ports are made first before you make any opening in the anterior segment. And then now here, of course, it was decided to remove both the, clear the anterior chamber and also the IOL. But one thing you will see when this is being cleared, you'll see that what looks like just white cornea and infiltrated cornea, when you start clearing off, you see this is a layer of exudative material, and you'll see over here how it starts coming out. You can see it's coming out from the lower part over here. It's got cleared, and now as the IOL was removed, the rest of the membrane can also be cleared from the anterior segment first, and that makes visualization of the posterior segment easy, which is what you're seeing here. You see this fibrinous membrane is almost always there, and actually a lot of visualization problems that you see and no glow and all is because of this, especially in exogenous endophthalmitis. So keep this in mind. This is another, sorry, this is the same video. Yeah, this is another one. Now you can see again the fibrin membrane coming out, this being taken out from the limbus. And once you remove this, the vitrectomy becomes easy. Actually, a lot of visualization issues are because of these anterior segment membranes. And this is what people fail to realize. But when we were doing conventional vitrectomy for endophthalmitis, we decided I don't want to approach the anterior segment at all. So what you see over here is, now you can see this again, extremely dirty anterior chamber full of exudates, and here if you look carefully, we are using this vitrector to make a PI in the upper temporal region. And look carefully over here, and you'll see the cutter movement start over here. You will see, once you see this, the cutter movement has started, and this completes the PI. And after you've completed this PI, you can actually clean that fibrin from the anterior segment, from this pars plana route. Even if some bleeding does occur, because it's very engorged with iris, it actually settles down very easily once, because the pressure is being maintained. It just clears off within a few seconds. You just continue the procedure. You don't need to do any diathermy or anything in these cases. And you can see again, this is a very, very thick membrane. This particular case actually had a very thick and sticky membrane. And yet we were able to clean up the entire thing, as you will see over here. And once you clean it, you will realize how clean the posterior segment is. Because it's an exogenous endophthalmitis, everything's gone from anteriorly. And the anterior part is worse than the posterior part, unless, of course, it's a very severe endophthalmitis which has gone up to the retinal surface. And you can see over here, this is getting cleared up. And the bleeding will also stop in the process. Now, you can see once you remove the membrane, or you also wanted to remove the sticky exudate from the from the iris surface, and I'm using this MVR to tease it off. And despite being extremely sticky, most of it, at least 90% of it, comes off, and you can complete. After that, you can see that behind you're seeing almost like a jet black pupil, and you can do that vitrectomy very easily, which is what is going on over here. No, it doesn't. You need an MVR to engage it. When you engage it, you'll see it's all the way up to the angle, and it separates out from the angle all the way up. And then once it's separated out that much, then you can use the cutter to cut it out. Sometimes you may have to go from the other side also and tease it out from that side also. So here, because it was very sticky, I used the cutter to actually cut it out. You can see this entire iris cleared up. Because this is infected. This is all infected material. You may do any antibiotic. With this so much exudation, so much infection, you'll get a recurrence. You want to remove as much of the infection as possible. And this is easily removable. It is not something which is difficult to remove. And then you do need to remove as much, because actually when you remove it from the angle, then only you get this pupil thing also clearing up. The whole thing comes off as a layer. Otherwise, you are stuck and you may end up cutting the iris if you try only to remove the central area. Now, once this is done, and if you still have a hazy media, then keep it in mind there is always epithelial edema, and debridement can result in a clear view in a majority of cases. It's very rare for stromal edema to be because of the haze, and in that case, the last resort is to use 50% glycerine, but I have not found it necessary. As Hemlata showed, despite stromal edema, the vitreous can be cleaned up. You can do an adequate vitrectomy.
So can we finish?
Yeah, this is the last
because-
slide.
Yeah.
A clear view is a prerequisite for successful surgery, and appropriate anterior segment management is the first step towards the same. So, ladies and gentlemen, that's the way to go. Thank you very much.
Thank you, Dr. Dinesh. We will not take any questions because we have the next talk from our instructor, and that will interest corneal surgeons. Actually, once you are doing a DSEC, you want a pressure of 60 millimeters of mercury to stick the lenticule to the cornea. And what I have seen is anterior segment surgeons, what they do, they press, they see the eye is hard. There is no calibration to see whether there is no calibration to measure what is the actual pressure inside the eye. And you have to maintain a pressure of 60 millimeters for 10 minutes to stick the lenticule. So what we have done, we have used a vitrectomy machine where you have an infusion pump where you can monitor on the vitrectomy machine what is the exact pressure. You enter into the eye with a 60 gauge, 30 gauge needle and increase the IOP to 60 for 10 minutes. You keep the IOP at 60 millimeters for 10 minutes, and then you don't, and what corneal surgeon do is they press the posterior lip of the paracentesis to decompress it. And many times during decompression, what happens, more of air comes and they again refill it. So here is a technique. He'll show one video where we have used a vitrectomy machine to monitor the intraocular pressure, and we reduce the intraocular pressure to 20 millimeters at the end of the surgery, and we don't need to decompress it. Yes, Dr. Ritesh.
Thank you, Dr. Gupta. So this particular video which I'm going to be showing is using two of our innovations here. This was a case which was being planned for DSEC, and our cornea surgeon, the first difficulty they were encountering was to really understand the anterior segment, how the iris is, how the pupil is, how the lens is. So we put in a chandelier illumination as we showed in for our cataract surgery. That chandelier when bypasses the corneal opacity, and it beautifully showed our cornea surgeon what kind of an anterior chamber were they dealing with. So it bypassed, gave us a good red glow, showed where the pupil is, where the PIs are, so that they could plan their surgery accordingly. Subsequently, the steps of DSEC were carried on as planned. The descent was stripped off, the lenticule was prepared. So this is being lenticule which has been put in the glide and positioned and through the scleral tunnel with the hand on the opposite side at 6 o'clock. The lenticule is put into the anterior chamber. This was a failed graft patient. So the descent was removed and this new descent lenticule was put in place. Now, post this, what Dr. Gupta was talking about is generally needed. Again, the position was checked under retroillumination from the chandelier. And now we put in the 30 gauge needle attached to our continuous air infusion from the vitrectomy machine. Now this fills in the anterior chamber. The pressure is set at 60. The cornea surgeon can then gently glide the lenticule into its centered position, keep it well centered on the eye. So slowly there you can see them manipulating the lenticule, keeping it in the center. The air fills up the anterior chamber, maintains it nicely full at 60 for 10 minutes. After that, to decompress, you reduce the pressure on the machine to 20. The eye maintains the pressure. You're just checking the pressure here, and subsequently just close the wound. Keep the infusion in place there. Don't allow the air to escape completely. Keep it at a lower pressure after 10 minutes. It keeps the lenticule in position. Your chances of next day having detachment of the graft is practically taken down. So that's a small trick from another small trick from our VR surgeon, which we kind of helped our anterior segment surgeons to use from our machine. Thank you.
And thank you, Ritesh. Any questions from the audience about the last and the second last talk? Any comments, ma'am? With this,
Thank you very much. With this, we come to the end of our instruction course. Thank you all for coming. I hope we had shared a few good points for you to take back with you today. Thank you.
Mistake for the genetics course. It went out.
वैसे तो ऑटो ले